Good morning and welcome to the SEAC and Sydney Infectious Diseases Institute webinar on pandemics in Southeast Asia. My name is Professor Greg Fox, the Interim Director of the Sydney Southeast Asia Centre. Today's webinar is jointly hosted by SEAC and the Sydney Institute for Infectious Diseases. SEAC is a leading Australian academic centre with partners of more than 10,000 academics, researchers, and policymakers from across the region. To begin today's webinar, we pay respect to the elders and communities past and present and emerging of the lands upon which we're meeting. In the University of Sydney, for thousands of years, First Nations people have shared and exchanged knowledge across innumerable generations for the benefit of all. And I'd also like to acknowledge the First Nations people across Southeast Asia. COVID-19 epitomised the importance of regional collaboration to tackle a major global health crisis. Back in 2020, we learned and were reminded of the importance of common shared responses to a new public health challenge that required the mobilisation of the whole of societies, from public health, economics, and science and academia. This problem epitomises many of the challenges that we face in the 21st century: complexity, volatility, and the importance of collaboration. And so it's exciting today that together we're going to discuss some of the lessons that can be learned about pandemics in our region. I'm delighted to introduce to you Dr. Yao Tong Chia, who's going to chair today's webinar. He is a senior lecturer in history curriculum education at the University of Sydney and the Sydney Southeast Asia Centre's country coordinator for Singapore. So, Yao Tong, I hand over to you to begin the webinar today.
Thank you, Greg, for the, and I would like to extend a welcome to everyone attending the webinar as well. And like Greg, I'd like to also acknowledge that we are on the unceded lands of the First Nations. In Sydney Uni will be the Gadigal people of the Eora Nation, and I also extend and pay my respects to the elders, past, present, and emerging. So today's webinar is an exciting collaboration of science and social science and humanities, because in our panel we have two medical doctors and a historian. So we are on this so introduce all three of them, and then I'll hand over the time to them. Dr. Seng Low, he is a historian and director of Chronicles Research and Education, and he's one of the topmost social historians in Singapore, and having published numerous books on many topics on social history in Singapore. And the most recent one, of course, is the book on pandemics in Singapore, 1819 to 2022, Lessons for the Age of COVID-19, which he co-authored with Professor Shi Li Yang. And so Professor Shi Li Yang, he's an infectious disease physician who is also the Vice Dean of Global Health and Program Leader of Infectious Diseases at the Swee Hock School of Public Health at the National University of Singapore. And he has co-authored two books with Seng. Prior to this book, he has also co-authored a book on history of tuberculosis in Singapore. Professor Ben Marais, he's the director of the Sydney Infectious Diseases Institute at the University of Sydney, and also he's also an infectious disease physician himself, and he has and he will be, and his expertise, one of the expertise is also on research on tuberculosis, and he will be responding to the talk by Seng and Li Yang. So they'll be talking for, Seng and Li Yang will talk for about half an hour, and during their talk, please feel welcome to post your questions in the Q&A tab. You can post your questions at any time during the talk, and we will then address the questions during the Q&A after Ben has spoken his response. So I'll hand the time now to Seng and Li Yang to talk about their book.
Thanks a lot, Yao Tong. I think a lot of work has gone into preparing for this webinar, so very thankful to the historians, social scientists, and scientists at Sydney University for making this possible. Great work you've done. I'm very happy, of course, to speak to people in Australia. I think the collaboration is very much needed. So I'm going to start first, and then Li Yang can continue about the more recent events and as well as what's going on in Singapore. I will be talking about the history of pandemics in Singapore. This is a book that just came out half a year ago, published by Routledge. It's the result of our collaboration for a heritage research grant by the National Heritage Board in Singapore. So hopefully this will become part of the cultural heritage, the medical heritage in Singapore. As Yao Tong was saying earlier, Li Yang and I have worked together for about six years now. We've written together a history of tuberculosis in Singapore, which was part of his school's antimicrobial resistance project. And after that, we were wondering what to do, and we realized that the old communicable disease center in Singapore was being earmarked for redevelopment, and we did a project on the CDC, also a National Heritage Project. The genesis of the book was written during the first year of the COVID-19 pandemic in Singapore, 2020. So we got the grant for the project, and we were doing the research, and somewhat in the middle of it, it became quite clear to us there's a book to be written. And for writing this book, I think I have to blame Li Yang, because he made quite a casual remark at some point that we seem to be fighting the last pandemic again, which is a reference to the SARS epidemic in 2003. So that struck my mind in terms of how in Singapore we are kind of always influenced by the last event, and we tend to focus and fixate on the last pandemic. One of the key questions in the Heritage Research Project was whether to include COVID-19 or not. So initially we didn't. This is quite strange, right, from hindsight, but historians often quite wary of looking at present developments. We don't have access to the archives, the documents on COVID-19. We only have publications, statements, things in the public realm. So, but the National Heritage Board kind of push us. Basically, they wouldn't have given us the grant if we didn't include COVID-19, so we did. And I think that has been a very useful decision and outcome for us, because we were always doing this research, looking at the connections between the past and the present. And as I'll say later on, the past and the present are connected two-way and not just one way. Past developments make us look at history look at present days issues in a different way, but it also happens the other way around. So this was the previous project that we did together on the Middleton Hospital, subsequently renamed as the CDC. So that project became a chapter in the current book. Okay, so just briefly run through the structure of the book. We try to do justice to all the major pandemics in Singapore history. The first chapter is on the quarantine, the development of quarantine in the 19th and 20th centuries, and how this was applied to the big three, the Holy Trinity of infectious diseases in Singapore: plague, smallpox, and cholera. So those are 4 chapters. And then there are 3 chapters on the big influenza outbreaks. In 1890, the Russian flu, of course, the big one in 1918, which was also huge in Singapore, and the last flu pandemic in Singapore before Singapore became independent in 1957. And we also looked more briefly at 2 quite significant pandemics in post-independent Singapore: the swine flu in 1976, which sparked off an attempt to vaccinate government employees, as well as the kind of prelude to SARS, the Hong Kong flu outbreak, the bird flu in 1997. As I said, one of the chapters in the book is the history of the Infectious Diseases Hospital, and that history, I think, is important in the sense that it posed this dilemma in infectious disease management. Do you want to build a dedicated hospital to infectious diseases, which is only going to be used in the event of an outbreak, which is usually very rare? So that dilemma has run throughout Singapore history. We looked at the rise of epidemiology and surveillance in the 1970s and how this began to supersede quarantine. The effect of SARS, which you can see now from hindsight, was a fairly small outbreak in Singapore, and how SARS cast a shadow on the containment of COVID-19 in the first few months. We looked upon, it's not possible for me to write a proper history of or even account of COVID-19, as I said. So we mostly looked at COVID-19 as a historical, as part of a history of pandemics that is a culmination of what had happened in the past in Singapore's encounters with pandemics, and hopefully there is a departure from that past as well, in that we can utilize more tools in grappling with the next pandemic. The conclusion rounds up the book with some lessons of history. So-called lessons, that's a big word we used, but actually it's really a call to look at history, to question Singapore's values and assumptions about history and about pandemics, and we also have some insights into what we can do in the next pandemic. So this photograph of the 1957 flu pandemic in Singapore. You can already see large numbers of people going to hospitals, so there was increasing acceptance of biomedicine by this time, but there was hardly any control of the influenza, and you can see no mask wearing, right? Wearing masks is not been part of Singapore history until COVID-19. So let me just run through the kind of principles by which we drew the lessons. So as I was telling Yao Tong earlier, this is basically History 101, what we studied in like the first year in our undergraduate course. So the principle is based on the concept of historicism, that history is unique, right? History is unique from the present and must be distinguished from whatever is happening in the present day, no matter how big the crisis is. So the past and the present are different. They are different because the contexts are different, right? Each pandemic occurs in a different context from others, and so we must pay heed to the differences. And the contexts are different because of change and continuity. A lot has changed between the past and the present, so there's no straight line between the past and the present. And when we talk about learning from the past, we are actually looking for questions rather than big answers. And one of the conclusions that we have in the book is history is one of the tools that the government and the medical profession should use in addition to science and governance. And history is actually not been properly understood in Singapore and what it can offer to real life contemporary problems. And one of the marks of the book is a focus on social history. As Yao Tong was saying, I'm a social historian. So history in the book is not just about case numbers or policy, but it's also about what people do, how people behave, the way they do, and what we can learn in terms of people's responses to pandemics, but also the policies implemented to control pandemics. So this is a photograph of one of the beautiful little islands of Singapore, St. John's Island, which was the site of the quarantine station until I think the 1970s. So those buildings are still around today, I think. And these are the wards where the passengers and crew of ships would be quarantined if there was a case of an infectious disease on board. Beautiful island, but the conditions were quite horrific. I'll come back to that later on. The photograph on the left shows the doctors and nurses who were volunteering to put up an emergency clinic in Chinatown during the 1957 flu outbreak, which really shows that the government of the times, which was led by locally elected local government, Singapore was still on its path towards self-rule, didn't do enough, requiring additional efforts from the community to try to control the spread of the flu. And on the right-hand side, the same flu pandemic in 1957, people resorting to their own remedies and whatever cures that had been proposed and circulated around in Chinatown, buying, the prices of these things were rising. So that's a sign of how pandemic control had largely eluded Singapore in most of Singapore's history, and people left to their own devices, and they had to find their own means and ways to survive. So in terms of the social history, I think there's a lot we can learn. In Singapore, the first is that there typically was a lot of resistance to government measures to control the pandemics. The British were never able to really impose a comprehensive and accepted regimen of quarantine or isolation of the various kinds of pandemics, right? Plague, cholera, smallpox, as well as influenza. Influenza, they usually did nothing. You find that people often avoid reporting to the police station or to the hospital cases of infectious diseases. In colonial Singapore, as in many colonies around the world, race was a big factor in the responses of the people. There was a divide between the colonial government and the different races that they wanted to control. The British complained about the Chinese and the Indians and the kind of rituals that they would carry out when they wanted to exorcise the demons associated with diseases. But the one that really struck me was what the British called the Mohammedan problem, right? That the Malays were not coming to the hospital and the Malays were hiding their cases in their kampongs. Class was another major issue. You find that a lot of the pandemics hit the hardest among the coolies in Singapore who live in the Chinatown area and the port area of Singapore. So this is a kind of parallel between what happened during the colonial period and the big dormitory outbreak in Singapore in 2020. The slaughterhouse, that was a name actually given to the quarantine station on St. John's by a commission of inquiry which found that the conditions there were horrific. The people being quarantined and the people being isolated were beaten up by the attendants on the island, who were more interested in rearing poetry and selling it to make money. However, the book does not just dwell on the difficulties between the colonial government and the people they ruled. We find that after the Second World War, there was indeed change and improvement in the relationship between the two parties. And this is what I call the vaccinated generations, right? People like me and Li Yang, who grew up vaccinated since young, which means that our parents had agreed increasingly to the use of vaccines and to the use of antibiotics and to going to a hospital when they fell ill, when they contracted an infectious disease. So the main point here is that people's perspectives and behavior are historical. They are not a given. In Singapore, there is a kind of belief that people do follow public health programs and measures. This is true, but this is something that's developed over time, especially after the Second World War. This is not a given, and it can change. Endemic histories have always been part of Singapore's experience with pandemics, and living with COVID-19, which was implemented in Singapore eventually, is not something new. It's been the experience of people in the colonial past who have had to deal with the pandemic. Once the government withdraws support or measures after the explosive outbreak has passed, people are mostly left to fend for themselves. This experience has always been difficult for most people. This would have, I think, anticipated some of the problems and difficulties when the government began to implement little breaks, right? When the policy of living with COVID-19 was implemented in Singapore. Finally, there's a two-way relationship between the past and the present, which means that the COVID-19 experience has, I think, underlined the need to do two things. Maybe the first is to rewrite the history of influenza. Influenza has often been written as a history of a slippery disease that cannot be quarantined and is impossible to stop the spread of influenza. I think the experience of COVID-19 now suggests that premise might need to be relooked. And also the history of quarantine itself. Quarantine has largely been discarded in Singapore in the 1970s onwards as something that belonged to the past, right? Of course, we know with home-based quarantine that this is not the case anymore. So those are the two ways in which the present also influences the way that we look at the past. Now, Liang, your turn. I can do the slides for you. Just let me know.
Thanks very much, Seng, and it's my pleasure to be here as well to speak to all of you and to learn from all of you. So as Seng mentioned, I'm a doctor by training, not a historian. And prior to meeting Seng, I was one of those who believe that history does repeat itself. Of course, you don't step into the same river twice. And as Seng has described, history doesn't really repeat itself in any real sense. In drafting this book with Seng, who did the bulk of the work, there were three major outbreaks in Singapore that we deliberately left out. One was on HIV, which is a very important disease, but nonetheless, much has already been written about it in different perspectives in Singapore. The second is tuberculosis. We did a book on that already, and so there wasn't a need to include this. And the last was typhoid, which is a disease that's still prevalent in many parts of the world. Again, looking at the COVID-19 outbreak and the work that was put in, we felt it would be a bit much to include typhoid as part of this book. But nonetheless, it was an important disease that defined much of Singapore's recent history. And maybe we'll revisit it one of these days again. But SARS is important in the context of how Singapore started preparing for outbreaks because it was the one major defining outbreak that led to how we dealt with pandemics in this modern era. And I myself have a personal experience with SARS, having lived through it in that outbreak hospital. I also teach medical students. And so one day, I think it was a year ago, I made a mistake of asking the medical students what they remembered of SARS. And then there was this laughter in the crowd, and someone told me they were like 2 years old at that time. So I think it's good that we talk about SARS and try to keep this memory for the future. Next slide, please. So I think for those of you who know the history of SARS, it started out as a mysterious respiratory disease in southern China, in Guangdong. At that time, China was not very open about how it shared news of its outbreaks. And in fact, there was the same accusation level at China today during the COVID-19 pandemic, but it was much worse then. So there were over 300 cases and deaths that somehow leaked out into ProMed Mail. At that time, it was dismissed as some kind of mycoplasma. But one of the doctors treating these cases in November 2002 on to 2003, went to Hong Kong for his daughter's wedding. Dr. Liu Jianlun stayed in the infamous Metropole Hotel in Hong Kong. And there, in a single lift, I believe, he infected about 9 people who went around to spread SARS around the world, 2 of whom returned to Singapore. Both were hospitalized in different hospitals. One of them recovered without infecting anyone that we know of. And the second one, an air stewardess, triggered off this huge, at that time, SARS outbreak in Singapore that ultimately led to over 230 cases and 38 deaths. So that's the hospital that the SARS outbreak began, Tan Tock Seng Hospital. And that's also where the Communicable Disease Center, or Middleton Hospital, is situated. Next slide. So as a consequence of the outbreak, Singapore, which then had a whole of government approach for all kinds of crises except health crisis, realized that actually pandemics and outbreaks also affected the economy severely and affected all aspects of life. And therefore, it should also be considered as something to be included in the framework for crisis management. Now, this seems very, very strange to us, having experienced COVID-19, that outbreaks are not really major enough to be considered a crisis. But I guess it's been a very long time past the memories of a lot of people in governments about the impact outbreaks can have on society. So after SARS, there was a deliberate attempt to include major outbreaks as parts of the whole of government approach. And we created different means of combating outbreaks, including to change our Infectious Disease Act, to change legislature. Again, this is something unique to Singapore because of the supermajority of the one party in power. Technically, laws can be changed very easily in Singapore, unlike in Australia or other countries. And we were able to use this in COVID-19 as well, because new acts of law, new changes to the Infectious Disease Act kept getting introduced as the old ones became redundant, and we needed to be flexible to stay on top of the outbreak. The second thing was, of course, having SARS made us think about updating the old Communicable Diseases Center into a new modern hospital. Seng has already related that from 2003 to 2019, 16 years had to pass before a new hospital was built. But again, we were lucky that the hospital came up just months, opened just months before COVID-19 happened. And straight away, we saw that this plan was not very good, because the hospital, we thought, was designed to cope with a SARS-type outbreak, meaning that it will hold up to 300 patients. And at a stretch, which the planners had deliberately designed it, it could be expanded to 600 but even 600 beds, as we know very well, was completely insufficient for COVID-19. And that's, again, I guess, one of the features about how we look at past outbreaks and design to prevent them, only to find out that new outbreaks and new pandemics require a different, more flexible kind of thinking. Next slide. So as I mentioned before, there are multiple lines of defense to tackle outbreaks in Singapore, and these were all detailed down in a way that made it seem like we were very well prepared. And perhaps indeed Singapore was one of the better prepared countries in the world, being a small island, although a very densely populated island. And I put this all here, right? Because in medical school, we don't often learn these things. But as we, I guess, get to work and encounter outbreaks, then we see how important these different things are. So there's surveillance and contact tracing, which was already pretty strong in Singapore. There's infection control and prevention. Border control is important. And healthcare, although we often say that doctors, nurses are frontline workers, but nonetheless, I think in the context of outbreaks, healthcare is actually a last line kind of thing. You don't really want to do it if you can. You want to prevent outbreaks at the start and have a minimum numbers of cases and deaths. But nonetheless, the healthcare system is both a front line in terms of attempting to detect new outbreaks and a last line, because if all else fails, then you would have to manage the patients that come in as a result of that outbreak. And then the rest, you know, right? Business continuity of essential services. There's a great need for good communication by leaders at all levels. There's a need for international cooperation to figure out how other people are doing and to learn information quickly. And then ultimately, when all else fails, there's a lockdown, which in typical Singapore style, we don't like the word lockdown, and we use circuit breaker during the time of COVID-19. Next slide. So the initial approach, next slide, sorry. So the initial approach, as I mentioned, was to deal with COVID-19 the way we dealt with SARS, although there were already signs at the start that COVID-19 was a completely different kind of disease. So we had SARS in 2003, where we shut down a hospital and we were able to contain cases despite technology being not very advanced at that time. It took 3 months before we had a reliable test for SARS, whereas for COVID-19, within weeks, and even before the first case came to Singapore, we already had a test ready to detect COVID-19. But nonetheless, because of the lessons in 2003 and a H1N1 outbreak in 2009, where essentially we didn't do very much because it was an influenza pandemic, we were totally unprepared for this Goldilocks virus. I mean, it's kind of an anti-Goldilocks virus, right? COVID-19 is midway in between SARS and influenza in terms of transmissibility and virulence, and therefore it wasn't something that at the start every country was prepared to deal with extremely seriously to try to lock down to prevent it from spreading. But at the same time, it wasn't mild enough that you could just ignore it, like the 2009 influenza pandemic. And so everything had to be unlearned and relearned again, and there were a lot of rapid changes in strategy, and the implementation of measures became the norm. In that single year in 2020 and subsequently in 2021, I think the Ministry of Health, which has the task of coordinating the outbreak in a healthcare setting, issued over 200 circulars to the hospitals with changes of rules. Sometimes every week they would change a rule just to keep up with the outbreak. Next slide. And then still we were unprepared in many ways because as I think one of the enduring lessons and the shame of Singapore during COVID-19 was that the migrant workers became badly hit. Singapore is heavily dependent on migrant workers. About a third of the population comprises migrant workers, many of whom are low-wage workers, come to do the kind of construction work, as well as the helper duties in households that Singaporeans ourselves are reluctant to do. So at the time of COVID-19, and it's back to these numbers now, there were close to about a third of a million migrant workers, mainly from South Asia, who dwelt in massive dormitory complexes that held between 5 to 20,000 workers. And on hindsight, it would seem obvious, but at that time, we didn't think that there was a real risk. And when the outbreaks happened in one dormitory and then started spreading to others, then we realized that we were in a terrible situation, and the government had to impose a new law that essentially curbed all movements from the migrant worker dormitories. At the same time, to prevent riots from happening, they had to step up to pay wages to the migrant workers, as well as to arrange food to be sent to the migrant workers every single day. So at the start, there was a lot of police that had closed off the migrant worker dormitories, and then to provide healthcare for the migrant workers, there were medical units that were set up for the migrant workers within their dormitories themselves, within the large dormitories. And we were extremely lucky in this regard because, as you know very well, COVID-19 is a mild disease for young people. And so although at the end of the day, I think close to half or more of the migrant workers were infected or shown to be infected by serological tests, but nonetheless, the number that died from COVID-19 or required hospitalization for severe disease was very low. And that's a lesson that we learned, and which we are now in the process of trying to think about for the future. Next slide. So these are the scenes from the pandemic, which I'm sure you may remember from your own experiences in your own country. There's all the queues for testing of migrant workers and frontline workers. Every day there's in the top left photo, there's airport screening, and then there's workers in scrubs, healthcare workers in scrubs that attended to patients in mass settings such as the dormitories. And then the last slide, at the last photo at the bottom, which you can't quite see, is actually the largest fish market and a fish port in Singapore that was closed because there was a COVID-19 outbreak. The Delta virus, many of you may recall, being the more virulent variants of COVID-19. There was an outbreak occurring there. Next slide. Yeah, so these are the numbers of COVID-19 in cases. They are in this white paper that was published by the Prime Minister's office after COVID-19, also detailing how we would deal with future outbreaks. So at the time, at the end of 2022, we had over 2 million cases of COVID-19 that we detected, over 1,700 deaths. And then there was a huge amount of money, 72.3 billion spent on the economy, and then a whole bunch of tests roll out as well as vaccinations roll out. Next slide. And then I'm just using this as the last slide because it kind of summarizes the learning from the pandemic. And ultimately, Singapore implemented a number of things that are still in the process of getting finalized and approved. One of which is to create a new communicable disease agency that would just focus on dealing with infectious diseases and outbreaks. Kind of like what Australia is doing now, setting up a new CDC that I think you have never before established as a response to the outbreak. And then there's a lot of pandemic-proof measures for housing for migrant workers as well, which I'm prepared to answer if you do have questions about them. But I'll just pause here, and thanks very much again for the opportunity.
Thank you, Seng and Liang, and I'll pass the time to Ben to have his response. Thank you.
Just wanted to thank Seng and Liang. It was really informative and also uplifting to see your frank reflections. So I'm just going to offer some brief reflections from the perspective of the Sydney Institute for Infectious Diseases, or Sydney ID. I think I should first of all say that I also have a very strong interest in tuberculosis, and we should recognize that tuberculosis remains the #1 infectious disease killer on the planet. It was transiently replaced by COVID-19, but it's like a pandemic in slow motion. It's something that also emphasizes all the split lines that COVID has indicated: the inequality, the stigma, the fear, the fact that we've got people hidden away in dormitories while we've got a different view to the world that we show to the outside. So in Australia, we had similar issues. In New South Wales, we've just before COVID opened the new New South Wales Biocontainment Unit, which was also modeled on experiences from SARS and Ebola. And similar to your experience, Liang, this is really the most sophisticated infection control unit in Australia, but was completely inadequate for the scale of the COVID epidemic. It's a wonderful resource to have, and we'll use it for future high incidence, low number cases, or high risk, low number cases like Ebola also, or other hemorrhagic fevers. But it did show us, similar to what you've said, that the emphasis should be on prevention and on the public health measures, that healthcare is the last line, and that's not where we want to act. I will touch on some of the lessons that you've mentioned, because there's lots of similarity, but also enjoyed your definition of SARS-CoV-2 as this Goldilocks virus that really filled that niche that was not always anticipated, of moderate severity but high transmissibility. And also the fact that it was spread widely by people with minimal symptoms or no symptoms, which made public health containment strategies difficult. I am glad you were willing to show the reality of the life that migrant workers have. We've got very similar situations in Australia, where we also have a migrant worker population assisting with fruit picking and other lower paid jobs. And often these people are very marginalized, and we don't always consider their best interests and how to serve them and keep them safe in times of crisis. I'm just going to very briefly reflect on a review paper, or really a summary paper that we published in the Lancet Regional Journal, that tried to distill key lessons learned from the COVID pandemic in Australia, with a very strong focus on being constructive and not pointing fingers. I'll just run through those key lessons quickly, which are very similar to what you've articulated. Lesson one was that border closures and lockdowns worked, but only as a crisis measure, as you said, a circuit breaker, and that we need a better understanding of when and how these measures should be deployed. Clearly, Australia was in the fortunate position of being an island. Singapore is an island as well, but we are somewhat more isolated, and we could close our borders for extended periods of time, which was highly effective in keeping the virus out until we could implement widespread vaccination, which was really the saving grace for limiting the impact of COVID in Australia. But it also came with major impacts, really population-wide impacts that was unappreciated at the time. And there's a far deeper understanding required of how we balance public health interests and the broader impacts on society and community. The same applied to disease modeling, which was lesson two, was that disease modeling was thought to be very helpful to guide decision-making, but it's absolutely essential that models are transparent and can be reviewed and criticized. Often models are used with an underlying political agenda, or to manipulate decision-making, and to retain trust. Whatever models are used for decision-making, I think, should always be open for peer review. At the national level, we struggled with the availability of data. In Australia, the jurisdictions, the states and territories, have constitutional rights or to ensure public health. So we don't have well-functioning systems for national public health data sharing. That was one of the key motivations for establishing a Centers for Disease Control, which is currently in process, and the legal framework is currently under discussion. The whole intent is to focus in the first instance on better data systems and better overview. So we can learn a lot from Singapore, and I hear that you are currently in the process of revising your structures as well. I think the fourth lesson was that the pandemic demonstrated the utility of advanced pathogen genomics. In New South Wales, we had a remarkable overview of the pandemic. Each introduction could be mapped, transmission change could be mapped. It really directed public health. At the time when the epidemic was still under control, obviously once population-wide transmission happened, it lost its utility, but it showed us the value that this can bring, and it has now been extended to a number of other diseases which predated COVID, but COVID really helped to demonstrate its value for things like Legionella or TB control, foodborne disease outbreaks. It also showed the value of new technology like mRNA vaccination, and I think globally there's obviously a huge focus on this. The Coalition for Epidemic Preparedness Innovation, or CEPI, has attracted billions of dollars in investment to develop a very clear agenda around being able to respond with an effective vaccine within 100 days for any future pandemic, which is a very ambitious target, but there's lots of great progress in that space. A very important social lesson was really around the need for timely, clear, and open communication. And it was clear that decisions should be evidence-informed, but it should also be as consultative as possible. You need to retain population trust. And we need far better systems to connect with our communities, to understand where people are at, and especially in Australia with its growing multicultural dimensions. In Western Sydney, where we work, we are among the most multicultural parts on the planet. And we needed a very specific response around health literacy and communication to really effectively communicate with those populations. It also showed us that our preparedness plans were highly insufficient in the aged care sector. And with a rapidly aging population, which is true for Singapore and Australia, we need far more thinking around how we structure our aged care sector to make it safer. Infection prevention and control was clearly very important. Many lessons learned, lots of debates around the exact and most frequent routes of transmission between droplet and aerosol. I think everyone agrees that aerosol transmission contributes and plays an important part. But more importantly, I think is really how do we implement effective infection prevention and control strategies at scale. Also minimizing the environmental footprint. I think one of the observations consistently across the world was that the infection prevention measures triggered by the epidemic has led to a mountain of plastic waste, a mountain of masks just discarded everywhere with major ecological impacts that we all need to struggle with. How do we minimize the environmental impacts of our medical control measures? As a pediatrician, we were very aware of the disproportionate impact of our control measures on children. So school closures had a dramatic impact on children's education, mental health, normal development. We now sit with a whole legacy of teenage anxiety, school refusal, increased inequality because children from rich families were able to maintain their schooling through distance learning. but it really increased the inequality within our communities. And like you said, children and young people had a very low disease burden. They were never amplifiers of the epidemic, but they were disproportionately impacted by our measures. Then I think two final things is that epidemic risk should be recognized as a standing threat. We have this waxing and waning, which is exactly what your historical overview have shown as well. Whenever there's a new pandemic, there's a crisis response, and then all the lessons learned just peters out over time. We need structures that recognize this as a standing threat and put processes in place, which is exactly what a revised CDC should hopefully do. And then lastly, I think the nationalistic responses that the pandemic triggered really strained global solidarity and regional engagement. And we can see the difficulties now in getting countries to sign up to the Global Pandemic Treaty. The way that the rich world has treated the poor has really damaged trust. It has dramatically increased the geopolitical tensions. The whole furphy around the lab escape theory has increased tension instead of increasing common purpose and focusing on important things like the wildlife animal trade, which was the real source of the pandemic. And then clearly we need to revise the international health regulations, but that is also going to need a lot of global goodwill and countries trusting that their best interests will be served when we make these international agreements, and that we will truly argue for the best outcome for everyone. I'll stop there in my reflections. I'll be happy to take any questions together with Li Yang and Ka-Seng.
Thank you, Ben. And your reflections have underscored the importance during that the pandemic being it's not just primarily a medical issue, but it has ramifications, and yet underscored also the importance not just of history, but also that of the social science and humanities in addressing and this issue and the problem is so multifaceted and so multidisciplinary. And as someone in education, I'd like to highlight also this point that you mentioned about that the pandemic, the COVID-19 has exacerbated and showed up the inequality of schooling that we see. It's there before the pandemic, and somehow the pandemic has just raised this and showed it up. So with that, I'd like to open the time for questions, and there are already seen some really good questions. I think we will, and I think you can see we'll go with the first question with Warwick Anderson asking about asking about comparisons between other places, Malaysia, Indonesia, and then also Hong Kong, and a comparison between them, and asking the question, is there something distinctive about Singapore's public health responses in comparison to these countries? So maybe Ka-Seng or Li Yang?
Yeah, so just very, very briefly, right? The book does look at the kind of colonial history of medicine. In addition to Malaya, there's a great book, and of course there's a lot of great literature from India, colonial India. So it looks at that literature, which kind of frames the encounter, right, between the British, the colonial government, and the Asian subjects, as well as the more global literature that's been written, especially in recent years, on things like influenza, which kind of is taken from a less global, less colonial and more global point of view. So we try to straddle those two literatures. As to whether Singapore is unique, we're not completely sure it is unique. Singapore has always been an open port city, and a lot of its practices have kind of been influenced by colonial practices as well as global practices today, as Ben was also alluding to. So there is a lot of shared similarities as well. if there's anything that's unique, just my own kind of view, right? It's, Singapore is ruled by the People's Action Party, and the keyword there is, of course, action. So this is a government that kind of acts quite quickly, as the white paper will show as well, right? All the different things to do have already been listed and are already in progress. So I think that is partly kind of the uniqueness of the Singapore case.
Liang, anything to add or?
No, I think Kasing has answered it very well.
I think there's a very specific question asked about the function of the Singapore Communicable Disease Center (CDC), and that and the core principles that this center will incorporate for pandemic preparedness to kind of so. Kasing or Liang, would you like to answer that?
I can do that. I think the Communicable Disease Center in the past was a hospital, literally, just a place to quarantine patients as well as to treat patients. And the other public health functions of disease outbreak control was handled at the Ministry of Health, which has both regulatory, legislative policy, as well as an operation function. So the new Communicable Disease Agency, the new CDA as envisaged, will take this function out of the Ministry of Health and place it within a statutory board, which gives it a bit more freedom to do things that the Ministry of Health itself is not able to do. You will also combine these functions with research, training, and education, which traditionally has not been under the Ministry of Health. And there will be a bigger component that relates to international cooperation, which in the past, Singapore, at least on the health front, has not been willing to do. So I think that kind of sums it up.
Thank you. Tamra, a colleague of ours is at Sydney Uni, has a question about what is being done to address the underlying environment and ecological factors that increase the risk of spillover events. So I think this is something addressed to Kasing, Liang, and maybe even Ben.
I think Ben will be the right person.
Well, I can just briefly comment that if anything, the COVID pandemic has re-emphasized the importance of us having a broader ecological awareness about emerging infectious diseases and pandemic threats. Clearly, the world is not good at dealing with things in a holistic, One Health, planetary health manner. That's partly why we have the problem with climate change and the difficulty in moving the global agenda. I can just say that at the recent World Health Summit, the whole theme of planetary health, or comprehensive One Health, just that it's best to just use these terms interchangeably. One Health in its broadest term means that the health of the planet that we live in, one planet, one health approach. Everyone recognizes that that's where we need to be. We all live on a very small and interconnected planet with very fragile ecosystems that are under severe stress. And we have a global economic system that is eroding the sustainability of those ecosystems at a very rapid pace. And we don't have easy answers as a globe. Similar to climate change, it will require us to think differently about the way we live and what we prioritize. In the case of COVID-19, we know that the trade in wild animals poses a major threat because it really increases the stress in these animals, multi-species contact, and also human contact. So that is one thing that needs concerted international action, but it's been lost completely, I think, around under the cloud of the lab escape theory. So we need a new generation of public health specialists who are able to speak the language of ecology, public health, infectious diseases, And our universities and training institutions need to think how to train this generation of people who can really address the big challenges that our globe faces. We don't have easy answers at this point in time.
And I think Warwick saying that his question, next question that he's saying that is follow up talking about whether there's the history of ecology framing of epidemics being maintained in Singapore, and he gives an example of 50s and 60s about the ecology of disease emergence done in the University of Malaya. So, any of you could like to comment on this or?
Sure. I think
Liang, yeah.
I think this is about the present rather than past. So in the present, there are a few national laboratories in Singapore that look at human microbiology as well as animal microbiology. And there are meetings between them, but the function has been kind of split up so that there is no one health laboratory the way Ben describes, or as what's happening in different parts of Europe, like Denmark, they look at both the human and the animal pathogens and they aim to correlate them. Singapore, of course, is a very small island compared to Australia. So we are far more interested in food security as well as the pathogens that could be brought in by food rather than animals. But nonetheless, there's an active policy of trapping dogs that swim over from across the causeway from Malaysia to make sure that they don't bring in rabies. And of course, we also actively look at the birds that migrate in, and we have sentinel chickens in the zoo to catch bird flu as they come in through our borders.
Thank you. And there's a question talking about, I think, Singapore's the question of masks, and then it's kind of a questions about political will here, about Singapore's legislative changes over this. One is when Liang, you mentioned about the dormitory outbreak and saying that, would it be that this has been, and the other one is about masks. So by when, Lee? So Kasing or Liang?
All right, this is by Hasina. I think she introduced herself.
Yeah, by Hasina, yep.
This slightly slanted question.
Yeah.
First off, for masks, that was one of the mistakes that we made in initially not recommending that the healthy people wear masks. And that was, again, because we were thinking of SARS, number one, where only symptomatic patients spread the disease rather than asymptomatic or mildly symptomatic individuals. And then secondly, this was not communicated well to the public. There was a big fear that there would be a run on masks if we told everyone to wear masks, and that would deplete the surgical mask supply for the hospitals. Of course, since then, we backtracked very rapidly when we learned that actually asymptomatic people could spread COVID-19. And I think after that, we're also more transparent in communications, in explaining the rationale for certain decisions, such as not telling the public we didn't want them to buy masks because then the hospitals would potentially run out of masks.
Thank you. Kasing, were you commenting something because you're muted?
Yeah, thanks. Just to add again the point earlier that there's no history of wearing masks in Singapore, and history is always important here because it sets precedents, it sets a tradition for people to behave. So in 1957, for example, when the flu swept through Singapore, the medical authorities were actually saying, forget about it, let it burn through, there's nothing we can do. So that has been lacking, even during SARS, and the wearing of masks was not encouraged then. So I think going forward, the question is, what will be the culture now that COVID has established a precedent? And Singapore tends to kind of swing, right, from one end to the other. When the government decides that this should be done, it goes 100% into it. But the issue, I think, in pandemic control in future is always about this tension between determination, political will, and flexibility, right? The ability to adapt to a completely new pandemic. So that's something that there's no easy answer to whether what should we do with masks, and in general, how do we govern pandemics?
You and we think due to time we'll just have answer the last two questions, and one by Terence asking about technology and how what actually worked. So Liang or Kasing?
Okay, I will answer this question as well, Kasing. So Trace Together, as some of you may know, is a Bluetooth contact tracing application where essentially if people's phones have this particular app, then they would know that they would be in contact with each other within, I think, 100-meter or so radius. And obviously this works very well only if nearly everyone has the Bluetooth application on their phone and are carrying it around. So initially it didn't work quite well, but after that, the uptake was sufficient that I think it became more valuable in terms of contact tracing and more precise isolation of people who have been exposed to COVID-19. And one of the ways that it worked very well was that they combine a number of functions with this app, including vaccination status, the ability to enter supermarkets and to eat at restaurants and food centers. That's always very important in Singapore. And that increased the number of people downloading and using that app, and that made it worthwhile. I think there were other countries that tried to implement similar contact tracing applications, and there's been mixed success because, as I mentioned it, you need a really high uptake for it to serve its function. But maybe Ben can comment, because I think Australia had a similar app as well.
Yes, very briefly, just to say that Australia abandoned the app in the end, partly because it wasn't seen to be very helpful. Also, once transmission became widely established, I think, and the awareness that no large number of people who transmit may be asymptomatic or may not have tested, it was seen to be somewhat superfluous. But it's definitely shown that technology gives us better options, and I'm sure in a future pandemic there will be even better use of technology. And at the moment, I'm not aware of anyone actively pursuing app-based development. There's definitely huge investment in getting better integrated databases so that we've got far better surveillance mechanisms if a future outbreak should occur.
Thank you. And I think that we have time. Let's have the final question is about the tension actually between the what I summarized as being the logic of quarantine, the purpose. There's the intention, but then there's also the tension between the ethics, because also decreased mobility, and that will be showing what Ben talked about, inequality too, because the mobility is different for different social classes and different groups as well. So there's this tension between them, and maybe this is something that's addressed to all three. A question that's addressed to all three of you.
I can quickly start from the Australian perspective, then we can end with the Singapore perspective. But just to say, in infectious diseases, there is always this uncomfortable tension of minimizing risk, but at the same time also minimizing harm to people. And the reality will always be, if there's a highly dangerous infectious disease, that the best way to contain it is to contain it at source. So what degree of social override there should be to prevent people from traveling and mixing will always be a balance. And you have to balance individual rights to, in comparison with protecting the wider community. Clearly, there needs to be a lot of communication and conversation, and the conversation should happen now, that we are better prepared when this happens. But it's not, it will always be a trade-off, because we need to protect the community as best we can, but at the same time, minimize the harms to individual groups at all costs, prevent unequal responses, anything that increases racism or differential policies to people in different economic strata should be, I think, criticized, and we should have principles in place that will guide our response to prevent harm, to minimize harm.
I'll defer to Seng. Seng, any lessons from our history?
You're deferring to me. I was going to say I agreed with the two doctors. The problems with quarantine have always been historical, right? In the sense that they are specific to the context in which they are practiced. So they are common problems, universal problems, but their issues have always been linked to the context and the crisis where they are used. So I think as a historian, the way that I looked at it is to say again that we should rewrite the history of quarantine. Look again at quarantine and its history, its application in history from the point of view of what we know now from COVID-19 and the lessons that we learned from COVID-19, so that we can kind of try to balance better this. It's not something that is part of history, is not in the dustbin of history, but it's very relevant today, so that we can better balance the humanistic and the public health aspects of quarantine.
Thank you, Seng. I'm afraid that our time is up. But before we wrap up, I'd like to also give a notice of events coming up for SSEAC. That's coming up next Thursday on Politics in Action, which we have Singapore is one of the countries that will be featured by Professor Kenneth Paul Tan. So, and for those who can't join in person, it will also be broadcast on Facebook, SSEAC's Facebook Live. And there's also, interestingly, another webinar seminar on Singapore's HDB history by Professor Chua Beng Huat, who is taking place at 4 p.m. Singapore time, 6 p.m. Sydney time. So with that, I'd like to, round of applause. Thank you to all the speakers, to Seng, to Liang, and to Ben for taking your time off your busy schedule to share your insights to all of us. And thank you all participants for your participation and for your questions. So thank you all and have a good day. Bye-bye.